Section of this video course, now we go to understand exactly the impression timing. In fact, we have seen in many cases that you can do an immediate impression, but that in some other cases it's better to move to a delayed impression. So in this moment with vertical preparation, especially with our approach, we have the immediate impression together with the dental preparation and the delayed impression. Now we are going in this video to understand exactly when it's better to do an immediate impression and what are the drawbacks related to the immediate impression and what are instead the advantages of moving the impression to a delayed stage, okay? Because we have advantages and disadvantages about both approaches. Honestly, we have zero disadvantages about the delayed impression, okay? The only unique disadvantage is that you have to wait 2 weeks, 3 weeks, that you have to again remove your provisional. If the tooth is a vital one, you have to again to do anesthesia. So the problem is about this. Instead, with the immediate impression, we have some real drawbacks that I want to analyze. I just want to do a small recap about the difference at the beginning between the edge approach and the edgeless approach. Because the preparation technique, the edge and the edges approach is highly connected with the impressions timing. So we know that after that we use our bar, we obtain, especially with the minimally invasive protocol, we have this for this kind of situation. We have the formation of an edge that I want to remind that it's not a preparation, the marking, it's just the limit of our preparation with the diamond bar and again the natural undercut of the tooth. And thanks to the smooth part of the butt bar, we have the removal of a small part of soft tissue, and so we are able to see just a bit more after our preparation. When we do our edge approach, our crown can start from that point of the edge, okay? Instead, when we do the other approach, the edgeless approach, you drill much more than you need. You have a vertical wall after the healing of the gingiva, and at this point you can move along this wall, deciding where is better to close your crown, okay? So, with the edge approach, you use what you prep for your crown in most of the cases. With the edgeless approach, you prep more, a bit more, or much more, or a lot more, and you can decide after, according to your clinical needs, where to close with your crown. So, when you do your minimally invasive approach, that it is the first in this slide, and you move with your bar deeper in the sulcus, you move your edge inside the sulcus. So that sometimes at a certain point, this can be really deep. And so we move to an edgeless situation, like in this case, okay? Your crown has to be in the sulcus. So you have to be careful that just not because you have a deep edge, you have to close your crown on that edge, but you can move with an edgeless strategy towards the vertical wall, along the vertical wall. So, in which situation we prepare with an edge approach and in which other situation is better to work with an edgeless approach? With the edge approach, we stay close to the gingiva. So we do usually supragingival margins or juxtagingival margins, and we are very conservative. I use this when I want to do an immediate impression because the harm that we have on soft tissue is very limited when we do this kind of juxtagingival preparation. We use this when we have sufficient height for retention. We use this when there is no dyschrony to hide, because in this kind of preparation we stay almost juxtagingival, so we have not the ability to mask any kind of dyschrony. We can use this, of course, when we have not to deal with deep decay. When we have a very deep decay, subgingival one, we have to drill deeply in that kind of area. I use more the edge when in the area where I have no aesthetic issue, like posterior area, where I have no need to do a deep margin elevation, always connected to a presence of a deep decay, and in some areas where I have no need to modify soft tissue and where I have no need to have a special emergence profile because I have no aesthetic needs. Instead, when I have different kind of needs that I'm going to highlight, I prepare just a bit more, even if I want to remember that edge or edgeless is not a strategy that you have to apply at 360 degrees. You can mix and combine both strategies on the same tooth. I always do the example of the anterior one. With the anterior one, you have aesthetic issues, aesthetic needs on the buccal wall. So you can do an edges preparation, a deeper preparation just on the buccal wall, but you can do an edge preparation on the interproximal and palatal wall in order to keep the whole biomechanical strength of this tooth. So edgeless is more on anterior area, but doing edgeless, because we go deeper, we have some harm to the soft tissue, we have some bleeding, we have to understand the healing of the soft tissue at which height, and we have also a very deep impression with the scarce ability to understand where the future healing will be. There is often the risk to delay the impression, and in these cases the delayed impression is highly advised. With the edgeless we are able to increase the length of our abutment and so to increase the retention. We can hide in a better way dyschromy. We can treat in an easy way deep decay because we can drill to the bone and after wait for the healing. We have more space for our technician, so we have more space for lighting, and so we can accomplish in a better way our aesthetic needs. We can manage in a better way our soft tissue, because starting from the subgingival area, we can build a nice emergence profile. It's also interesting to understand that when we have some small periodontal problems like 3, maximum 4 millimeters of probing, doing a deep edgeless vertical preparation is the best scaling that we can do on our teeth. It's the best scaling because you do a very perfectly clean surface and a very smooth one. So about the timing of the impression, the immediate and the delayed, as a general rule, when I do an edge preparation, I do an immediate impression. When I do an edges preparation, I do a delayed impression. Now, if you have no time and you did an edge preparation, you can do, for any reason, you can move to a delayed impression. But I want to really advise you not to do an edges preparation, especially a deep one at 360 degrees, and combine with the immediate impression. When you mix edges preparation and immediate impression, it's like running on a fast car. And when you run on a fast car, don't complain when some things get wrong. Okay, this is what happens when you want to go faster than you can. I want to show you a mistake of mine, because we learn in a good way from our mistake. This was an old crown with a relapse, with a decay under the distal side of this crown. This was the old crown, this was an old PFM. This was after the removal of the old crown, and look how deep was the decay. There was a huge subgingival decay. Of course, you know, we are able with our approach to isolate this kind of teeth. I did my papillectomy, I put my dam, I put 2 clamp, I put the Teflon, I put everything, and I have been able to isolate this tooth and the concavity. You see, I put a post, a rigid one, for many reasons. This is a part of the isolation with Teflon that I want to share with you, because when you deal with this sort of concavity on deep margin, we have always the problem that the rubber dam being stretched on a straight line is not able to isolate this kind of areas. So we need to improve our isolation, and the best tool to obtain this is to put Teflon. But what is important is you can put Teflon. I always use the spatula, especially at the beginning, in order to stabilize Teflon. But it is important to understand that these cases are better managed after matrixless, because with Teflon you are able to obtain your isolation. But if you touch Teflon with something, you can have some bleeding coming up. So when everything is stable like this and you have everything, just do a matrixless restoration and after trim everything with your butt bar. Okay? This is the best solution that you have for deep margins, because placing the matrix in these cases where you have this difference of height between the mesial, for example, and distal palatal part is very challenging to do everything. Okay? So here I did my restoration, my distal. You can see on the X-ray how deep I am, and I did my edges restoration at 360 degrees, also because I had some problems on the mesial wall because of the previous restoration, and I did my very deep restoration. And I did my impression. So what is the problem when you do this? When you do this kind of deep impression, you have a lot of problems. The first problem is that you have to deal with blood, and so it's very easy to have some bubbles. Now, we know that with vertical preparation we can move along the vertical wall, and if you have some small bubbles in some non-critical areas, we can go over them, okay? But you have to deal with this kind of problems. But the other big problem is that we give to our technician a very deep impression of the sulcus. And the technician has a lot of space, a lot of vertical wall between the equigingival part and the bottom of the impression. He has sometimes like something like 2 or 3 millimeters of wall. And it's very hard on 3 millimeters to understand where exactly to put your crown. In some cases, in a lot of cases, your technician will tend to place the finish line too deep, and when you will receive your crown after the healing of soft tissue, you won't be able to place your crown because of ischemia on soft tissue. Tissue will become white and the patient will experience a lot of compression of soft tissue, like if you are probing with some force, okay, because the crown is too deep. And if you do the delivery of these deep crowns, in many cases you will have problems of inflammation. Okay, the choice of the area where finish your crown is unpredictable, is hard, and in most of the situation your technician can do a mistake. I want to show you the technician made the zirconia frame, and look here, this is on the distal side. Here we are close to the bone level. This is the day. Okay, I started to try the crown. The patient was feeling a bit of pain, but look, I was marking with the pencil, like I showed you doing the provisional trimming. I showed the pencil, and look here how subgingival is going this crown after more or less 1 week. We want to be just 0.5 millimeters inside the sulcus, and look here instead how deep I am. Look distal. Look distal, I have to cut something like 2 millimeters of the crown. Okay? And doing this, I almost destroyed this crown. And so my technician was forced to do a new one. At the end, I waited for the healing, and I did again a new impression and a new crown, because I was destroying everything. This is the crown the day of the delivery. Okay? And this is the crown after almost 2 years. Okay? But I did the immediate impression, and after I did the mess, and I've been forced to do again a second impression after the healing. When you mix the edgeless approach with immediate impression, in many situations you can experience some clinical problems. You have just to know this. This is the root hole. You see that when we do everything in the good way, the soft tissue response is always good, but if we place our crown with too deep margins, we will pay the price, and the price is gum inflammation and bleeding. I show you another case. This was another edgeless and immediate. Look here, the black line that you see on the stump is the marking on the abutment of the juxta gingival level, but look how deep is the impression, okay? How deep is the impression? Look, these small bubbles, because to keep everything dry is not so easy. Our technician has to choose between the green line and black line where this crown will land at 360 degrees. And I have to say that my experience is that it's not easy at all. Where to stop? Instead, if we wait, look here, how much space. Instead, if we wait the healing, if we wait 3 weeks, for example, the healing of the soft tissue will be a perfect guide for the impression, because the healing will say to us the right space, the available space, the good one that we have for our crown. Okay, you see here, for example, this is the superimposition of the immediate impression and after the healing, where the crown will start. Okay, where you see the green is more or less the bottom part of the second impression, while where you see the edge is the bottom part of the first immediate impression. Look how much distance there is. If you give the first impression to your technician, in most of the cases he will start close to the end of this impression. And look instead, look where is the right emergence profile, where to start. So when I do edgeless, like I did in this case, I wait 3 weeks, I wait 20 days for the perfect healing of the soft tissue, and after I take my impression. Of course, you need another appointment. If needed, you need anesthesia. If the tooth is vital, you need to place cords, you need to do retraction like I did in this case, but the result is much more predictable. Okay? And I place my crown. So I do 3 appointments: preparation and provisional, impression, and delivery. In easy cases, you can do instead the fast system, and you can do the immediate. Look this case. This is a case that was similar to the previous case. I removed the crown, again a very deep decay. I did the isolation, again I am close to the bone crest, Teflon, liquid dam, second clamp, everything that's needed. Here there is, I show you that I am on a dry field and I am doing my prosthetic build-up for my future crown. I do this freehand because if I try to put a matrix at this point, it's almost impossible in a so deep margin. I did my preparation. Look on the X-ray, I am close to the bone crest, but I wait. I wait 15 days. This is the healing after 15 days. And this is the immediate instead. And I did the impression in this case also because I have been, we can say, lucky that there was August, that it is holiday in Italy in the middle. I did the impression after 40 days. This is the crown delivered 1 week after the impression. Immediate. And look, because when you do these cases with this so important papillectomy, you have a soft tissue rebound after a while. Okay? So don't look for deep margins on this kind of crowns. And this is after 27 months. Look which kind of soft tissue rebound and maturation you have. Look here on the palatal side. After 27 months, the healing of the soft tissue, the relation of the crown and the soft tissue. Okay? To anticipate this sort of healing, the day of the papillectomy is so hard that the room for mistakes is so high that honestly, when you do papillectomy, never do the immediate impression. Okay, this is my advice. look here instead how much predictable is this work when you wait the correct times. For example, this was an 83 years old lady that came in my office without an old crown. This happened in the period of the COVID, so I was not able to do the initial preparation, the oral hygiene. I just did the first preparation and I tried to solve the problem. So she was without this kind of crown. The tooth was still vital, probably because of the age. There was some retraction of the pulp. Okay, also you can see that there was not so much visibility of the pulp. So in a case like this, for example, what is my reasoning behind? I have to isolate the distal margin of this tooth. But if, for example, I have to do this because I have to cut the papilla, I will wait for the healing for 3 weeks, 4 weeks. In this case, for example, I put some Teflon in that area for retraction, and I have been able, without harming the soft tissue, to do a correct isolation. I did my build-up, and I did my vertical preparation, okay, with an edge approach. You see the soft tissue? There is no bleeding at all, and there is no bleeding because I did nothing deep into the soft tissue. In this case, so I have been able to take immediate impression. You see the edge? On the buccal you can see the edge. Look here carefully. Okay, so if you are able to work without harming too much the soft tissue, if you work with an edge approach, if the tissues are quite good, you can do an immediate impression and save one appointment. But if in this case, for example, I would have cut completely the papilla for an easier isolation, I would wait 3 weeks before doing anything else. Okay, so this is the case, and this is the case after 1 week where I did this crown. After the period of COVID, we were able to go on with other kind of restorative treatment with oral hygiene and something more. But in that period, I was keen to complete this work. But look here, the soft tissue after 1 week. Okay, with edges preparation, you can do this. But if you harm soft tissue, you have to be careful. Monolithic zirconia crown, landing in position.